And in many ways, it's like kind of bringing the humanity back into healthcare, which, you know, can feel a bit like, maybe too much from the heart, not enough from the head. But in fact, the research shows that when you bring all three inputs together, your outputs are much stronger, they're more sustainable, there's more buy-in, people's quality of care is higher, the actual health outcomes are higher.
Welcome to Disruptors at Work, an integrated care podcast. Today, we are diving into co-design in healthcare, shifting from designing for people to building systems with them. Let's get started.
Hello, I'm Cara English, special host for today's episode, and I'm joined by Christa Haanstra, founder and managing director of 4C Strategy. Welcome, Christa.
Thanks. I'm so happy to be here.
Thanks for joining us. So, Christa, I know quite a bit about you and have worked with you for a while now, but for those who are meeting you for the first time, can you tell us a little bit about your background and what motivated you to pursue the path that you're in?
Great. Sure. I'm Christa Haanstra. I've worked in healthcare pretty much my whole life, and I've actually worked with people with lived experience my entire life. But early on in my career, we just talked about them as families or patients. And as my career progressed, about 10 or 12 years ago, I had the privilege of working in an organization that really valued the input of people with lived experience or people as partners. And we started to talk about co-design and engagement and really thinking about how to actually talk to people with lived experience as equals in any process in healthcare, to design change, to design new programs, and to improve quality of services for those for whom the services exist. And so, although I've been working with people with lived experience my entire life, I sort of formalized my commitment to that and commitment to co-design and engagement about 12 years ago, and have been working in that space ever since, and have had the privilege of meeting with and working with people around the globe who are leaders in this area to really figure out how do we change culture in organizations and change attitudes and approaches so that we can bring people with lived experience to the table as equals in any conversation around healthcare. So although I've been working in healthcare for a long time, I sort of formalized my commitment or my understanding and really honed my skills around co-design and engagement in the last 10 to 12 years.
Nice. Thank you so much for that background. For me, I would like to just share with the listeners that we met at an international conference on integrated care and have had a really nice opportunity to connect on so many different values of, what we see in terms of our vision for the way healthcare, could move in a direction that really engages with communities and neighborhoods and, like you mentioned, people and families, rather than, taking it from the science and reinforcing hierarchies of, the doctor knows the best. The doctor gives the prescription or the instructions, and the patients either follow or they are considered non-compliant or non-adherent. And so many of our folks in the Doctor of Behavioral Health program who are learning to integrate mental health and lived experience and social determinants of health into the picture of a treatment plan and a care team, discussion are being met with a lot of resistance from those that have been educated or accultured over time in their working experiences, to really reinforce those hierarchies. And so I would like to invite you to talk a little bit more, because I've learned so much from you about what is co-design, what does that look like, and talk a little bit about some of the research that supports the use of co-design and meaningful engagement.
Absolutely. Co-design and engagement is really about understanding people's experiences as an equal input to, say, research or reviewing or analyzing data and processes and accountability metrics. And so I often talk about it as the kind of three-legged stool, right? So
Yes.
we usually look at research deeply. We look at all the numbers. We look at the outputs. We look at the reports. What we don't look at is the nuance of the experience of those who are actually using the services. And in many ways, it's like kind of bringing the humanity back into healthcare, which,
Yeah.
you know, can feel a bit like, maybe too much from the heart, not enough from the head. But in fact, the research shows that when you bring all three inputs together, your outputs are much stronger. They're more sustainable. There's more buy-in. People's quality of care is higher. The actual health outcomes are higher. But not only that, those who are working in a space that values this often rate their staff, like the staff satisfaction levels are much higher.
Yeah.
And so it's really just about looking at a third input and giving it equal value in a process of quality improvement, of designing a new program, of changing a program, designing an entirely new organization, whatever it is. It's really thinking about how do the academic, the literature, the research, the data, how does that actually play out for the person for whom the service exists? Which,
Right.
when you talk about it like that, sounds like common sense, and yet it's
Exactly.
much harder than
Yeah.
we think. And part of that is what you just talked about, is the hierarchy, right? We
Mm-hmm.
go to school and we learn, and we've been in that role of being having that hierarchy reinforced over and over and over again. And not only that, when you think about especially leaders or physicians or people at the top end of their practice, those are people who have had to apply and be successful in getting in. And so everything is sort of, for lack of a better word, a competition.
Yes.
And only the best of the best get in. And so then
Mm-hmm.
to ask those people to sit around a table, literally and figuratively, with people for whom their experience is their actual lived human personal experience, and
Yeah.
treat that as equal input, is a really big shift in an organization or a department. And
Yeah.
so that's where the challenge comes in, because when you talk about it the way we do, just
Mm-hmm.
use experience as a third input, it
Mm-hmm.
makes common sense.
Yeah.
But it's much harder than it sounds.
It is. So I think it would be helpful, because we met before this, because we are working together on a couple of projects, and one of the things that you mentioned to me was a strategy could be, well, let's see how this plays out in real life. So, I think it might be helpful to the audience to hear how using that experience might help a physician gain a better understanding, or a nurse practitioner or mental health provider. So I'm thinking, for example, of my father, who had a quadruple bypass a couple of years ago, and the discharge plan included sending him directly home with my mom, who is half his size and half his
Yeah.
weight. And
Yeah.
he was not able to get out of bed, even to, get to and from the bathroom or the laundry room or the kitchen on his own. And she was not able to obviously physically support him. And they had a home nurse who came every 3 or 4 days or so to check in. But, it ended up not working out well for him. His outcome was very poor, and the stress of being unable to provide that care in the home environment for my mom really weighed on her and caused her to have some unique health issues that came out of that, both in the short term and the long term.
Yeah.
And so I think, just talking with the care managers in the hospital, because he actually had to be readmitted for a second surgery.
Yeah.
And talking with the case managers about, how's this going to play out when you discharge him? They live 45 minutes from the hospital, and my mom can't get him out of bed. What does that look like, versus can he go to a cardiac rehab center?
Yes. Yeah.
So let's talk about what this looks like. Let's talk about the unfolding story in real life, because the vast majority percentage of care is being done at home, and on the day-to-day basis by the person themselves, by their caregivers / family members, and sometimes based on community resources that no one at the hospital in the larger city has thought through. Are they even accessible, available, open?
Yeah. Yeah. And I think that's, I often hear people talking about how do I even get started on this? And for me, I just say, really, truly, in any conversation, just ask the question of how does this actually play out in real life? Like, let's use a scenario and kind of pressure test our assumptions and see if it's going to work or not. And that example is the perfect example, right? You can follow best practice, but if someone is half the size of the person they're caring for, all of those best practices go out the window because they're simply not possible. And we hear that story a lot of times. So it's really about using the nuances of that person or that family's individual circumstances, and using your skills to adapt what is best practice to work for them. And the only way you can really do that is to work really closely in collaboration with that family to ask and understand the reality. When we think about co-design and engagement, it often plays out at multiple levels. So you're talking about point of care. So, that appointment interaction one-to-one with a clinician or clinicians. It happens at a governance level in an organization. It happens at a program level in an organization. And where we see it most, or kind of where it is the most commonly integrated, is at an innovation or research stage.
Right.
And so, you see it integrated at many levels. So people get a bit overwhelmed around, okay, I'm a clinician in a large organization. How do I bring this to my practice? And for me, it is that question of, let's talk about how this is going to play out for you. So I think we used an example earlier, like, what if there's an hour of therapy required each day for a child, and yet that family lives, is housing insecure, is food insecure, doesn't speak English as a first language. And the idea of carving out an additional hour each day to do something is not going to happen. So how do we talk to them about integrating it into what they're doing already every day, which is just a slight nuance to what they're recommending. It's just about working with them to figure it out so that they don't come back and say, well, you've been non-compliant, which is
or they just don't want our help.
Right.
Which we still hear.
Or they come in and they want us to do everything for them.
Yes.
And it's this real blaming environment where if we talk about bringing that humanity back into healthcare, and just adapting what we know as best practice into their particular circumstances, and being able to work with them to do that.
I love that so much, because change is really big for systems. Change is also really big for people. And so asking, for them to figure out how to fit a treatment plan into their lived experience without asking about their lived experience seems violent to me. It seems like something that, we used to, it should be perceived as something we used to do that we're no longer doing. Unfortunately, the mindset of providers has been educated in a certain direction. So the true, the love that I have and the deep respect that I have for this work is really shifting that right back to the humanity, the humans who are doing all of this and who need the care and want the help and are coming in for care, but may not be speaking the same language or receptive to, being told what to do without even feeling like who they are and what their life is like.
Yeah. I use kind of a tongue-in-cheek example just because it's something people can relate to, but also I'll just explain it here because I think it'll make sense to people. We can be talking about the exact same environment, but have two distinctly different experiences. Mm-hmm. So let's take a reception area in a family doctor's office. Typically, and I'll describe it in the jurisdiction that I'm in, which is in Canada. Mm-hmm. Typically, you walk into an office, the person who is the receptionist or the person who's greeting you is sitting down on a chair, often behind a glass barrier of some variety. Mm-hmm. You come in and you're standing up. So in order for you to have any eye-to-eye contact, you have to bend down. You don't have a chair, typically.
Right.
And so you're talking about if you're going to create quality or you're going to do some kind of quality improvement initiative in that reception space, you cannot only take it from the team's perspective because the experience of that exact same physical space is very, very different. And sure, that's a very simple example, but most people can understand that. They can picture
Right.
it, they get it, they can remember bending down to be at eye level with the person
And
that you're
talking
trying
through
to,
the little glass
and
hole.
talking through the little glass hole. There's all of those things. Now, I'm not saying any of that is wrong. I'm just saying if you wanted to create a better experience for the people who are coming into that office, you could not do it by just looking at the data, just looking at the research, and just understanding the perspective of the person sitting in the chair but on the other side of the glass. You have
Absolutely.
to understand the experience of those coming into the office. And so
Yeah.
it's just a good example of how we don't know the 360 view of things until we ask people from a 360 view perspective. And that's the other big piece about co-design and engagement is I'm not only talking about asking the patients and their families, we're talking about all the people involved in a particular scenario. It could include the cleaning person, the environmental services person who's coming into the room. There's a study that came out in the UK, this is a number of years ago, where patients were asked who the number one person, most important person in the care was, and the answer was the person who cleaned their room, because they saw the same person every day, and it was the person they saw most consistently. And the system is aghast at that. To think that the person who is cleaning the room is the person they see as the most important. They're the ones who ask the question about the family and how are you doing and how are you feeling, not from a clinical perspective, from a human to human perspective. And so we have to think about how do we integrate that person's perspective when we're thinking about change, as much as the physicians and the other clinicians and the family and the patient themselves. So it's really that 360 view of experiences that are overlaid on top of the data and the research in order to get the full picture, and then be able to build solutions that take all of that into consideration.
Yeah.
And the one way I kind of talk about that, we talk about co-design.
Right.
I always say you have to co-define the problem or the scenario before you can even get close to co-designing anything. Because if you don't have a common understanding, you're coming at it from two different perspectives.
Right. Absolutely. I completely agree with that. And it kind of reminds me of one of the cases that we had presented to us in my initial doctoral work about a single mom with a son who was coming in for counseling services. And by any measure, the therapy had been a success. The kiddo was doing better at school and at home. Right. The relationship between the child and the parent was stellar. But the rating of the services in terms of they were using this My Outcomes measure on, whether or not therapy had done its job and it was time for it basically to be done. And the mom kept rating it at about 50%. And it turned out nobody had ever asked mom, what's the value of this service? And the value for her was that she was receiving support and reassurance from the therapist in doing the job of parenting a kiddo who had some specific needs. Yeah. And without the therapy, there was no touch point with the system. And she felt like she was going to be adrift, without any support line. They were going to sort of snip the balloon cord there. Yeah. And so I think just even simple questions about, what do you feel like you need rather than what's your therapeutic goal for, the patient, even just shifting the perspective to remember that the person in front of you may have a very different reason for being there than you do. And you may have been trained in a way to get to the bottom of a clinical goal that is very separate from the reason that even brought them in.
Yeah. And I think that leads me to another example that we often use. It's also an example out of the UK where a doctor, his name's Dr. Hiro Tanaka, shares the story of how his mom went to his hospital. He was the head physician, and he was so proud of the experience she had. She had a very scary health episode while she was at his house. And he looked at all the metrics, and he looked at the file, her health file, and everything. If you were to use only that as the evaluation, they would have got almost, an A+ on their outcomes. And then he said that to his mom. Oh, mom, how did you like my hospital? And she said it was horrible. And he was like,
Mm-hmm.
wait a second, what do you mean? And she said, I didn't know anything that was happening. No one introduced themselves. I was
Mm-hmm.
scared out of my mind. I didn't think I was going to come out of there alive. No one talked to me like a human. I never knew what was going to happen next. And so
Yep.
the experience was horrible. But if you look at only the outcomes,
Yep.
it would have looked like it was exactly what everybody wanted. And
Yep.
so again, it's just that nuance of adding that third leg of the stool and
Mm-hmm.
understanding the experience. It's very,
Yeah.
very simple. Like we looked at, I can remember a program, a co-design and engagement program where one of the things was I never know who is talking to me. They all wear scrubs. I don't know
Oh,
whose
sure.
role is
I don't know
what.
who's who. Sure.
I don't know who's who. And so they had this visual of the team on the wall so that every
Mm-hmm.
patient would know who was coming to talk to them when. And
Simple.
again, that was a code, simple, not a high cost thing, but something that then translates into higher rates of satisfaction from patients and families when you're looking at that service, just like you talked about. There's often, and I don't want to say they're always, there's often simple solutions to big
Mm-hmm.
problems or problems that contribute to low satisfaction rates. There's
Mm-hmm.
often very simple solutions. And so I think part of it is this fear that if you bring people with lived experience to the table, they're going to want something that you can't deliver. And
Right.
that could be true. So we have to
Mm-hmm.
all be prepared for that.
Right.
And there's often steps along the way that are much simpler that can
Mm-hmm.
make a huge difference. I don't
Yeah.
want anyone to walk away thinking that if you do co-design and engagement, you're always going to come up with simple solutions. But
Right.
there are often simple solutions that can make a big difference
Yeah.
along with the very big changes.
Absolutely. And if you sit around a table and you're with a working group that's looking, for example, at vulnerable populations, unhoused populations, with very chronic, episodes of care or acute needs or, very difficulty accessing, how do we find a person to provide
Right.
ongoing longitudinal care, problems that are very complex. And you're sitting around a table with healthcare providers coming up with solutions, and you ask the question, what is the smallest thing that we could do differently that might engage this person a little bit better? You are going to come up with some great solutions to start with. But what if you ask the person?
Yeah.
Because the person's answer is going to be probably very different than all of the clinical mindsets in the room. And that's okay.
Yeah.
It's not about who's right. It's about having the engagement
Yeah.
between, the person who is seeking care or who you are seeking to care for. And, how can we make a partnership so that I love that you said, considering the lived experience as an equal input to
Yeah.
all of the clinical training and
Yeah.
the research, because so often I hear doctors complaining about, well, now that people have ChatGPT, everybody thinks they're a physician
Yes.
and they know
Yeah.
more than me. But I don't think it's about that. I think it's about recognizing that when people have information, they can ask better questions. And
Yeah.
so as clinical providers, being prepared to meet people who have information at their fingertips on their smartphones that are causing them to think deeply about their health and their health over time, and the fact that they want to live a quality life, and that they're coming to you to ask a deeper question than just, can I get a prescription for, water pills, or can
Yeah.
I get a prescription refill? How can we value that more as a clinician community,
Yeah.
instead of being annoyed because
Or
most people who
threatened
I
by it.
talk to, yes, feel as though they are a burden when they ask questions, and
Yeah.
feel that they're often being dismissed. So I think it's that, can we shift our culture in the direction of the mindset of co-design
Yes.
and engaging with individuals who want to share their lived experience,
Yeah.
and can we learn to value that more?
So there's two things in what you said I just want to respond to. One is, I think part of what we're asking at the point of care as a co-design and engagement approach is to really adapt what you know clinically with the support of the person in the room. So really like using
Yeah.
those critical thinking skills that you have honed through all of your years being trained as a professional, and using that as kind of your like a really key element of your care delivery, right? Is to be able to adapt. Okay, I understand all of these things from the research, from the literature, from my own experience, and here's this person's distinct experience or environment or setting. And so how do I now take what I know and adapt it so we can come up with solutions that
Yeah.
work for them? So that's one. So kind of almost thinking a little bit differently about how you apply your knowledge in an environment where people are coming with pre-existing thoughts about what they want or need.
Yeah.
The other piece that I really want to touch on, and again, like I've been in this space for 10 to 12 years, so we often start co-design engagement with people who we feel comfortable with around the table, people who look like
Yes.
us, people who might be
Yeah.
educated themselves, maybe not as a healthcare professional, but in another profession. And so you typically lean on those people as your kind of first go out. And I know that we want to get a representative view from all the people we are serving, but you have to start somewhere. So for me, I
Yes.
say, just get started and it will grow as you grow. But the question I often get, because I've been in this space and the people I'm working with have been dealing with this for a while, is how do we reach, either we can call them hard to reach populations, or as you called them,
Yeah.
vulnerable populations. And I think a lot of people assume, okay, well, we're not going to ask children what they want in a pediatric setting. And I'm like, yes, you are.
Why not?
You're going to adapt it for the
Yeah.
child. And so I think about when I worked at a children's hospital, they actually brought out a whole variety of different types of foods and had the kids, they didn't ask them in a formal way, which foods do you want? They watched them gravitate to different types of foods. Again, obviously all healthy choices, but what are they gravitating towards, and how are we going to create a menu for our kids that they'll actually eat that's going to meet nutritional needs? And so there's an example, right? It's a
I
very
love that.
simple example, but a reminder that, yeah, you are going to ask the kids, but you're not going to ask them in the way that you would ask an adult. Another example that I think is really interesting and something to consider is a vulnerable population. I can think about an example very locally here, where there was kind of an unofficial low-income housing. It wasn't provincially or municipally run. It was kind of this unofficial building that many people who were either housing insecure, might have been dealing with mental health or addictions issues, were living in.
Yeah.
And there was obviously a recognition that they needed access to healthcare and other supports and services, but there was a huge gap. So what did they
Yes.
do? They literally put people in the lobby of that building and just casually asked questions. It wasn't formalized. It wasn't this barrier to entry. You have to be there at a certain time. You have to come to a room that you're not familiar with. They went to them. Very simple, common sense, but often doesn't happen.
Yeah.
And in the end, what they did was the health services ended up renting a room in that building, and everything that the people needed was in that room. So there was no barrier to
Wow.
getting access, because they had to go to a building that they either weren't familiar with. Even if
Yeah.
it was 100 meters away, it was oftentimes too much of an effort. Not because they didn't want to, but because they had to go into a formalized setting that they weren't comfortable with. It wasn't something they knew. So they co-located the services most needed by the people in that building in that building. You weren't
Wow.
adding professionals. You were just relocating them to a different spot, right?
Talk about humanity and restoring, it just seems to me that that is a great example of saying, if you take all of the, clinical know-how and you say, okay, but where does it need to be put? And then
Yeah.
you say, and who is this for?
Yes.
That is the solution. And I just think of so many who, would turn their nose up at wanting to be a clinician in the type of environment,
Sure.
as well as so many clinicians that I've known who would say, yes, that is me. I want to go and do that. So I think, again, you right place, right time, right person for
Yeah.
the job, as well as, individuals who would be receptive to care
Yeah.
in that kind of environment. But the solution is there.
Yeah.
And I think this is what I love so much about co-design, from the steps and the principles and the three-legged stool. That the idea is that the heart of the carer or the caregiver, the person who goes to school to be a clinician, who wants the knowledge, if you ask them why they do it,
Yeah.
surveys and research on nurses and mental health professionals have typically said the top reason is because I want to help people.
Yeah.
And the second reason is because somebody helped me and they inspired me to be like them.
Yeah.
So this is exactly what,
Yeah.
to me, that means in action. It's those aspirations in action.
And
So,
and I will say one final thing that I say all the time, but it's maybe obvious, but it's also kind of points to the problem. I've been working in this space for 25 plus years. I have yet to meet a clinician who goes into work every day thinking, I want to make the lives of patients or families more difficult.
right.
They don't. That's not why they're in
It's
this
moral
space.
injury to be put in that position. And
It's
so
the
many of us live that
systems and the
life,
way
and
that
the
we
system
set
does
things
it.
up that is
Mm-hmm.
causing that to be a challenge, right? And so I always
Yes.
say this isn't a shame and blame exercise. It's about
Right.
how do we create an environment that works for everyone. And that example of co-locating space within an unofficial low-income housing unit is a perfect example. It's not going to be for everyone who wants to work
Right.
there, but the people who do want to work there are going to have higher rates of satisfaction from a job perspective because they're actually seeing the difference, and they're not seeing all the people fall through the cracks like they were before
That's right.
because of the barrier of having to make an appointment, show up at a specific time, go into a building that doesn't feel comfortable for you, where you might be feeling
Yeah.
judged. Maybe you've lost track of time for a variety of reasons. Like all of the things that are barriers to getting the services they need, they get
Yeah.
to see that happen because it's actually happening right where the people are. You're
Right.
going to them and you're
Right.
providing them what they need in a way that they need it. And what's the added cost to that? Honestly, the added cost to that is the rent. And if I'm not mistaken, for that one particular place, I'm pretty sure the owner of the building actually gave them the space for free because they recognize the
Mm-hmm.
value as well.
Which is an amazing community partnership. And again, it presents a solution to a problem in
Yeah.
that, so often we say, oh, well, it's not safe, it's not permitted. There are always going to be a lot of reasons not to, or that might get in the way as barriers. And those they're important, and yes, but how can we remove more of the barriers and coming up with creative solutions by partnering
Yeah.
with others in the community where the care is needed,
Yeah.
and probably less of a barrier access, for specific populations in that way to begin with. And also for the provider who wants to be doing the care, but
Yeah.
is being told you got to be behind the walls of a hospital. Maybe I had a student who did her culminating project on creating or basically buying refurbished vans and fitting them out with psychiatric medications, as well as some of the medications like methadone and Suboxone, for individuals with addiction diagnoses, but who were also actively fighting those diagnoses and providing both mental health and psychiatric and medical care
Love it.
in a van,
Love it.
and that has worked in some communities. There's some really good research behind it, but funding is always a challenge, and it's almost through a grant that is
Yeah.
short term, and
Yeah.
the expectations are so high, and sometimes even if they hit those metrics, matrices, they're
Yeah.
still not getting a renewal of the grant because the funding is uncertain,
Yeah.
and yet they make the most difference. So
Yep.
anyway, well, Christa, we could talk forever.
Yes, we could.
I want to say thank you so much. You've definitely explained this concept, and I'm really grateful to you for providing not just our audience today, but also our faculty and our students with extra advanced training in this subject. And I definitely want to send a message to all of our students and our alumni and our faculty in the CGI community, especially, to just say, let's keep going with this idea. Let's keep asking the question, because this is how we renew hope in ourselves as a community who wants to help people, who wants to, has the vision of improved healthcare for all. And let's definitely connect on this and see how we can come up with solutions to get maybe around some of the barriers that have been put in front of us.
I love it. I encourage everyone to just ask that simple question about what does this look like in real life. And I think what I hear from people who do that is they feel a renewed sense of hope, but also a renewed commitment to what they're doing, because it suddenly has that practical application that makes a real difference.
It definitely feels a lot different than waking up in the morning and saying, I dread going to work, or I dread going because I'm either going to be met with an environment that I'm not going to be able to do what I came here to do, or I'm not going to be able to meet with the people that I would really like to help or serve. It certainly puts that, that emphasis and that compass point back on, oh my gosh, I'm excited to go and do, what I came here to do.
Absolutely. Thanks for having me. I love talking about this, so happy to come back.
Yes.
Anytime.
Thanks so much. I love talking about this too, and I love talking about it with you. So thank you for taking the time to join us.
If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. Until next time.